Good evening, ladies and gentlemen. I'm Dr. Roger Girion, and I am the Executive Director of the Department of Mental Health here in the hospital. And we're really pleased to have all of you here this evening. It's a very nice turnout on a cold night. I was very surprised the night, the opening game of the World Series. How many people were here that night? It was standing room only, and it just shocked me because I thought, well, I didn't realize it's the opening night of the World Series, and I didn't think anybody would show up. But surprise, the place was packed. So it shows a real interest on the part of people in this community in mental health and subjects of psychology and psychiatry. This is our own community psychology today, or as I call it, psychobabble today. But I want to tell you first a little about our hospital. That we are an inpatient, we have an inpatient psychiatric unit here, and we have 420 beds in the hospital here. We have an emergency room that sees 120,000 patients a year. The hospital sees 220,000 admissions per annum per year. We have the only level 2 trauma center around here. So if you're going to get banged up, this is the best place to get treated. Some of the best, finest trauma surgeons around. We have 450 physicians on staff. We have 450 volunteers. Total of 2,500 employees in the hospital. So it's a very active hospital. We have a NICU, neonatal intensive care unit here. We have the home, this is home to the Institute for Heart and Vascular Care here in the hospital. And we are an accredited chest pain center, and we deal in advanced primary stroke center and STEMI receiving center. So if somebody's going to have a cardiac procedure, this is an excellent place to have it now. And we're recognized as a National Comprehensive Community Cancer Center here also, and we're associated obviously with City of Hope. And this, we have a strategic partnership with City of Hope. Now I want to tell you a couple things about why we do this mental health lecture series. One of them is to introduce to the community some of the clinicians that we're so proud to be affiliated with and associated with, as Dr. Shah is. We also have a red theme that kind of runs through the talks, and that is that every relationship that we have flows through our relationship with ourselves. And the stronger our relationship is with ourselves, the stronger our relationships with others. So one of the goals with this lecture series is to help us with our relationship with ourselves. Everybody actually has conversations with themselves, whether they do it out loud or, we program how we feel with our conversations with ourselves. So it's even okay to answer yourself. Now you don't want to get caught saying, huh, because then they'll. But we're proud this evening to introduce Dr. Shah, who is Chief of Psychiatry at Kaiser Mental Health, Behavioral Health System. And he is a marvelous speaker. I've heard him speak before, and I'm proud to call him a friend. And without further ado, Dr. Shah. And by the way, just one other thing, housekeeping. All of you have a little survey that you can fill out with your name, your address, or email address and phone number if you wish to be contacted for future lectures. There's also a handout for the next lecture, which will be on parenting. So feel free to fill those out and just drop them off at the table when you leave, and welcome. Thank you.
Thank you, Roger. Thank you, Dr. Girion, for that very nice introduction. I'm not quite sure when you heard me talk. I mean, I talk all the time, but...
Well, that's your group.
Oh, yes, of course. Anyway, good evening, everybody, and welcome. to this talk on dealing with depression. And I don't know how many times I've talked when I've been both audio taped and filmed, so no pressure on this. I just hope you all get to buy the DVDs. Okay, so what we're going to cover today is the topic of depression, and specifically, kind of Dr. Girion in his flyer kind of laid out the agenda. So I'm going to start off by talking about the differences between sadness, or kind of something that all of us feel, and what we call, as psychiatrists, we call depression. And then we'll talk a little bit about the possible causes of depression, and then a little bit more in detail, in depth, about the types of depression. And then we'll cover briefly as to how depression can vary between men and women, which is important, and how depression can manifest itself in children. And finally, we'll talk about treatment options for depression. And I'm hoping that throughout this talk and through this talk, thank you, I'm hoping to normalize depression and remove some of the stigma around mental illness in general, depression in particular. So depression is something that has kind of been talked about through centuries and different civilizations, and there's so many different names for it. I mean, this is just a kind of I was playing with this, but I could have doubled the list, and we call it, officially used to be called melancholia up until 100 years back or so. And of course, we all know about sadness, mourning, grief. We'll talk about the blues that we have. So clearly, different people have approached the issue of depression from kind of different angles, given it different names, emphasizing different aspects of depression. And so this is a very, very brief overview, kind of a dirty overview of the historical conceptualizations of depression throughout the history of Western civilization. And if you think about how depression has been thought of, then throughout history, they've talked about depression either being caused by something outside of ourselves. A few thousand years back, it was demons and spirits. Actually, not even a few thousand years back. As late as the 16th, 17th centuries, it was something that you did that made the gods angry with you, or it was there was kind of the more sociological theories which became popular in UK and then spread to Europe in the 17th, 18th centuries, along with the Renaissance, about poverty and homelessness kind of being kind of a cause for depression and social isolation. And then kind of along with this, there were always these theories which talked about depression being something which came from within, whether it was a black bile, that was Hippocrates, the first physician, the first Greek physician, who talked about depression being caused by too much black bile, or whether it was an imbalance of the humors. The Greeks had a theory of the 5 humors and the liquids. More recently, we talked about chemical imbalances, which I find to be just gobbledygook and a kind of a modernized version of the imbalance in the humors. And of course, everybody's favorite theory nowadays is defective genes. The real change in the last 3,000 years of civilization of talking about depression has not, I think, been so much this that we have now come up with the extrinsic factors or intrinsic factors that really make a difference. I think we still have very little idea as to what they are. But I think that instead of, and this is what I want to emphasize, what historically there was a tension between the extrinsic causes and the intrinsic causes, to the point up until 1970s, there were these 2 different types of depression, endogenous depression and exogenous depression, as if one is caused by internal factors and one is caused by external factors, as if the two depressions are different. And instead of this tension, what has been replaced is more an interplay of factors. An interplay of extrinsic causes, which we now call stressors, which can include, well, not the demons and spirits, hopefully, but poverty, homelessness, social isolation, and a lot of other financial stresses and interpersonal issues and what have you. And they all go into stressors. And versus intrinsic causes, which I would, and this is my word, but I would kind of summarize as the resilience that all of us have. So you may be more resilient to certain stressors and you may be less resilient. And that resilience is something which is something that we develop. And yes, genes play a part in it, early upbringing plays a part in it. I'll talk about an important developmental stage that I think plays a huge part in the development of resilience. But the resilience, if you can think about resilience, it's the psychological equivalent of immunity. So we all know that some of us get sick very easily, right? We get colds 5, 7, 10 times a year. And others, even though they may live in the same household, be exposed to the same viruses, never seem to catch a cold. And then it is explained as the one person has greater immunity than the other person. Well, resilience to me is psychological immunity. It's the same kind of concept at a psychological level. And that resilience is both from genetic factors, definitely, but also early developmental and early childhood factors. And it's kind of unique for each one of us. So each one of us has a different level of resilience. And so if you can think of, how they used to have those U-tubes to measure pressure, and you put mercury in it and you measure as to how much atmospheric pressure pushes the mercury up the other side. Well, that's kind of the concept of resilience and stressors. It's an interplay between the two. So if you have more resilience, you'll need more stressors to make you depressed. If you're less resilient, it would take fewer stressors to make you feel depressed. But in the end, and I think this is important, all of us are vulnerable to depression. It's not, in my opinion, this kind of mental illness which is kind of, only confined to the crazies and the genetically vulnerable and only in some families. No. Every single person in this room, under the wrong circumstances, can become depressed. The question is how resilient you are, and given your resilience and whatever you want to call it, luck, chance, the slings and arrows of an outrageous misfortune, how much stressors you're going to have to kind of overcome that resilience. And so from a theory of a tension with people fighting whether it is intrinsic or extrinsic, we have come to a realization that it's really an interplay. It's not nature versus nurture. It's nature and nurture. And I think that's the 3,000 years, and that's all we had advanced. But that's important. We'll take it. So, let me say the same thing in a slightly different way. If you look up what mourning means, grief, right? And the symptoms of grief, and we have all experienced grief, have you not? We lost a loved one, and whether that's through death or divorce or through separation or however that there's a loss of a loved one, and we go through a process of mourning, of grief, and we feel sad, we kind of withdraw, right? That's one of the classic things of mourning. We withdraw. We no longer want to interact with the world. We no longer want to kind of go out and go to the movies with our friends. We no longer want to do all the fun things, do all the things that we used to. Kind of lose our passion in that sense for life, for things outside of ourselves. It's kind of think about mourning as kind of the psychological equivalent of what happens when we have an extremely painful toothache, right? You don't want to think about anything else. You're just completely within yourself. It's that kind of the energy that we have been withdrawn back into ourselves to lick our wounds, so to speak. And then this is accompanied very often by loss of sleep or appetite or energy levels or concentration, right? While most people who have grief and mourning do not actually become suicidal, how often have I heard that, oh, I wish I could join my wife who died, or my son who died, or whoever it is, my father who died. And so there is this kind of a passive, more passive death wish, if you will, not an actual suicidal active death wish, which is common. And there's often some loss of self-esteem, especially if the mourning is for a, say, loss from a divorce or a separation or something like that, which is not entirely natural. And then you look at melancholia, which is today called depression. The reason I use those two words is because of a famous paper by Freud, which was the first one to clearly differentiate between mourning and melancholia, between sadness and depression. And so today we call it major depression, what used to be called melancholia. But the symptoms you'll see are very, very similar: sadness, depressed mood, hopelessness, loss of energy, appetite, sleep, concentration, social withdrawal, loss of interest in pleasure, preoccupation with death, low self-esteem. So what's the difference? What's the difference between what we all feel as sadness, as mourning, as grief, and what we mental health clinicians call major depression? Well, there's several answers to that. The commonest answer given is that depression is longer and more severe than mourning. I find that to be a very arbitrary. Who is to say that if you mourn for your wife of 50 years for more than a year, then you are depressed? Until then, it is normal. Or if you mourn to the extent that you lose weight, then that is abnormal. That's depression. I think that to differentiate mourning and melancholia, to differentiate normal sadness and depression based on severity and length, is very arbitrary. And I, by and large, disagree with it. Sometimes people talk about what caused the sadness. So if you lose somebody that you loved for 50 years and you were mourning for 1 year, then that's okay. But if you lose somebody that you only known for 5 years and then you mourn for 1 year, no, that's depression. How can you be so depressed for a year if you only knew the person for 5 years? Well, clearly, that's also a very poor criteria. I think the real and the most important criteria is that you have something in major depression which is absent in mourning, and that is irrational guilt. A kind of a unreasonable, illogical blaming of oneself for what's happened. This may not come out immediately. It may be something that the person themselves keep kind of hidden because they recognize it's illogical. But most of the times, if you talk with a person who has true depression, you'll find this irrational guilt. And this guilt, this kind of self-blame, is what leads to suicide or suicidal thoughts, right? Because the thinking goes, oh, I'm the cause of this. I do not deserve to live. The world would be better off. X or Y would be better off if I died. And that's what guilt leads to. And then, of course, there are complications to depression, such as hallucinations or delusions. And when those are present, Everybody know what a delusion is or a hallucination is? A hallucination is seeing something, having a perceptual kind of experience of something when there is nothing there. So if I see my wife sitting there, that's a hallucination. Or if I hear a Martian talking to me, that's a hallucination. Or if I smell rotten apples, that's a hallucination. Or somebody farted. No. Sorry. Did I put you off?
You're making me laugh. How is a hallucination different than a dream? When I'm
During the waking state.
sorry?
During the waking state. Very good question. Hallucinations are dreams while asleep. Dreams are hallucinations while asleep. Sorry, said it the wrong way around.
So it's normal to have hallucinations while you're asleep.
It's normal to have hallucinations while you sleep. There are also other conditions where it's normal. It's not, for example, it's very common in so many cultures to hallucinate somebody who has just died who has been very close to you. And it's actually considered to be a bad omen if you don't have that hallucination. So there are many other conditions in which hallucinations are normal. There's also something called hypnopompic and hypnagogic hallucinations, which is hallucinations in that twilight zone between sleep and a wakeful state, which is not a dream, it's a hallucination. So they are normal hallucinations. But by and large, hallucinations are a symptom of a problem, bigger problem. Well, a delusion is a belief which is culturally dystonic, which doesn't go with your culture, and which is unshakable. You cannot reason a person out of that belief. So, for those of us who are atheists, a belief in God is not a delusion, because that's cultural. Many people believe in a God. But if you suddenly start believing in the lizard people ruling the world, and you're absolutely unshakable in your belief, oh, that's a problem, right? What were they called? Illuminati that rule the world. Yes, they do.
On your previous line, you put best under irrational guilt, best and IMO.
Oh, in my opinion. I'm sorry. That's the best way to differentiate between mourning and melancholia. I'm saying in my opinion, and which is kind of somewhat grandiose of me, because that's actually what Freud said. It's not just my opinion. But anyway, I can take credit for it. Okay, I'm going to probably go over the most complex part of today's talk. Bear with me a little bit here. A 6-month, 8-month-old infant, right? We all know they experience separation anxiety, right? That's all of those who have parents or grandparents or uncles or aunts. They've seen that in a 6-month-old, 8-month-old. Now, what is technically separation anxiety? Separation anxiety is when, until 6 months, if there's no mother or a caregiver, and by the way, when I use the word mother, I'm using the word mother as a primary caregiver. The gender doesn't matter, biological relationship doesn't matter. It's a relationship of caregiving that defines the mother. So the primary caregiver, if there is no caregiver to the infant, right, 3 months old, 4 months old, and the infant becomes hungry, the infant starts to cry. And we state that as a symptom of anxiety, right? But the interesting thing is, at that age, 3 months, 4 months, whatever, the infant will only cry if they're hungry or wet or have colic or whatever. They're not going to cry just because there's no caregiver. Around 6 to 8 months, a dramatic change happens in the infant. The infant looks around, scans the room, sees no mother, no caregiver that they recognize, and they start crying. Even though they may not be hungry, even though they may not have a wet diaper. This is called separation anxiety, because the infant now anticipates that in the absence of a caregiver, their needs are not going to be fulfilled. So the infant has actually, it's a major cognitive developmental stage that an infant now recognizes that it's this particular caregiver out of all other kind of adult figures in their world, shadowy adult figures in the world, that is responsible for my change in my diapers or for feeding me or whatever it is, right? And the absence of the mother, the caregiver, the primary caregiver, leads to separation anxiety. There is no way to parent a child in such a way that they do not go through separation anxiety. You'd have to have a bevy of 6 or 8 primary caregivers all lined up, right, to replace one another. Oh, I'm going to the bathroom, you replace me, in order for a child not to, and it would be horrendously bad for the child not to have separation anxiety, right, because the child is not going to be able to learn how to deal with their own frustrations. So separation anxiety, to be a bad enough parent that the child has a separation anxiety, is actually ideal. And Winnicott had a term for this called good enough parenting, right? So you try to be ideal, you don't reach the ideal, you reach the ideal 70-80% of the times, and that's good enough. That's actually the best. And so that's why we have separation anxiety. But now let's take it a step further. Let's say that a parent, for whatever reason, I'm not into parent blaming here. For whatever reason, the parent is absent for a much longer period of time. Not for the 5 minutes or 15 minutes that most of us are absent when a child cries and we cannot immediately come to their aid. Let's say we are absent for, or the parent is absent for 5 hours, 1 day, a week. What happens to these children? Well, there was this psychiatrist, Dr. John Bowlby, in London, who was very interested in knowing what happens to those children. And what he did was, during the Second World War, unfortunately, there were a lot of orphanages in London with a lot of children because parents were killed in the bombings. And he studied the different infants in the different orphanages, and he kind of rated them as to how good a bond a child was able to develop with any one particular caregiver. And many of the infants, some or the other staff at the orphanages, most of them in those days were run by nuns, but many of the infants by the staff of the orphanages were kind of adopted. They were like, oh, this is my special child. And so they had a primary caregiver, even though it was not a mother or a father. But then there were some infants who, for whatever reason, maybe they were uglier, I don't know, did not have that kind of primary attachment to one person. And Bowlby studied what happens with them. And a remarkable thing he studied. And he found that after a certain period of time, which is usually in minutes to hours, that anxiety turns to anger. So the infant who has been separated from a mother for, let's say, and these numbers are arbitrary, but let's say 15 minutes, will show anxiety followed by pleasure when the mother comes back. The infant who has been separated from the mother for 2 hours will show anxiety followed by anger when the mother comes back, not pleasure. And then what happens if those 2 hours becomes 2 days? The infant will not care. The infant will reject the caregiver, and they will be in a state of detachment. And this then becomes so severe that the infant will actually fail to thrive. The infant will not accept the food given to the infant, will not accept the nourishment, will actually die. The earliest type of suicide. That's not what people call it, because that's very politically charged to say that a 10-month-old infant is committing suicide. But that's basically what they're doing. They're choosing not to have nutrition. This disorder, which he labeled failure to thrive, now has become medicalized. What we call it nowadays is reactive attachment disorder. That's today's terminology, but he called it failure to thrive. And he was the first one to show systematically that you do need love to survive. Air, food, water, clothing is not enough. You need love. But if you go back to talk about depression, so in my opinion, this axis from anger to detachment is the bedrock of later depression. That's what depression is. Kind of vacillating between anger, because there's a lot of anger beneath many people who are depressed, to detachment, withdrawal, and not wanting to live anymore, which obviously is also present in a lot of people who are depressed. And this whole concept of maternal deprivation and how much maternal deprivation have we had, to me, is the biggest factor in how much resilience you're going to have. Remember we talked about resilience? So the infant who has never really reached anger stage too often, and that's also very difficult, but has never really reached the anger stage too often, will be very resilient to depression. While the infant who has been in the detachment stage may have lifelong depression. And that kind of is, I think, what truly differentiates resilience. Okay, that was the toughest part. Any questions? Yes.
Is that the bottom kid, Edward G. Robinson? Is it?
I do think so.
It kind of looks like.
Yeah, he didn't change much. Yes.
An adult, how long can the time differences span from going to the stage anger to the detachment stage? You said for a baby 2 hours.
No, those are arbitrary. Those are completely arbitrary numbers.
Right.
And there is a genetic factor here also. Some babies can take much longer periods of separation than other babies can. But an adult should not, hopefully an adult is not going to be, I mean, we all become angry, but the point is an adult is not dependent. So it's not a deprivation. The reason, remember, and that's why I went into the theory of the separation anxiety, the reason why a child is anxious and angry and detached and all that is because the child anticipates that their needs are not going to be met. Hopefully as an adult we can meet most of our needs.
I was kind of thinking on the terms of abandonment issues. Like that could happen with adults or children, right?
They happen when you have these issues as a child. That's my point. This becomes a bedrock. So this becomes a template of how much resilience you have. Right? So let's say that if you haven't quite reached the detachment stage, but travel down the anger pathway, and this is these are all, I mean, this is a continuum, right? I mean, here we are putting milestones to kind of name them, but it's a continuum. But let's say you travel down the pathway from anger to detachment a fair number of times without actually reaching quite the detachment stage. You're going to have major abandonment issues because you're going to be very kind of sensitive. Oh, she didn't call me for 13 minutes after I texted her. I don't think she loves me anymore. Right? Well, if you haven't done that, you're much more likely to trust she'll come back because she always does.
So this is just referencing the maternal stages of children from, when they're born. This doesn't follow suit with adults. 'Cause I've heard it does go from anger to anxiety to suicidal thoughts in the sense of how depression works with adults. But this isn't-
I am saying that's how it works. This creates a template.
Okay.
That's a template that we kind of. Another way of thinking about it is that this is the structure that we internalize. This is our worldview that we internalize.
So if a person was to take something for anxiety, does that prevent them from going to the anger stage, or does it make them go there quickly?
We'll talk about medications in a minute. I don't think medications are that simple. And I don't think medications quite work on the same kind of bedrock structures that these things are at.
Even if it was like a supplement, a herbal supplement.
Same thing.
To calm yourself.
Same thing. I don't think that this would be more, if you want to have something that, as to how treatment would affect, it would be long-term therapy. As to that would be more kind of.
Experimental kind of.
Excuse me if you already answered this, but I missed it. You're talking about this in infants. Would it be true in young children as well? Say 4 and under, 3 and under? It's really infancy.
It's really infancy. It's when you're that dependent. By age 3, you're not that dependent. Right? You're much more mobile. I mean, if you're a normally developing child, you're much more mobile. You have many more resources. You have language. You can communicate. So you're not. This is the state of helplessness that is created in the infant because the anticipation that a lack of a caregiver will mean that my needs just cannot be met. I cannot do anything. Right? Okay. As I said, this is the most complex part. And so if you put it all together as to what my view of what sadness and depression is, sadness and withdrawal are normal reactions to loss, originally of the mother or the caregiver, later on of loved ones. This sadness and mourning may tip over to depression if the loss of the stressor creating the loss is greater than the resilience, our capacity to handle it. And the resilience is determined by genes, early childhood, social support systems, physical health, external resources, a lot of different things kind of go into determining our resilience, which also means that our resilience is dynamic. It's not that you have X amount of resilience and that's what it will stay throughout life. No. If you, let's say if you go through a bad marriage and breakup and divorce, your resilience is going to go down. Or if you go through financial troubles, your resilience is going to go down. If you move to a strange town and don't know anybody, your resilience will go down because you have less social support system. And then when it tips over to depression, it needs to be treated if it is severe or prolonged or complicated by guilt, suicidality, or hallucinations, right? So this is just all the slides that we kind of put it all together. How are we doing with time?
We have another 15 minutes, but 12 minutes, but if you want to leave time for questions.
Oops. Okay. Well, we've been fielding questions, but anyway. Okay, so just some depressing stats about depression. 1 in 14 Americans will get depressed in any given year. 1 in 5 will get depressed over a lifetime. That means that in this room, there will be about 7 or 8 of us who will suffer from depression in our lifetime, if we have not already done so. It's the leading cause of disability, 15 to 45 years old, almost 45,000 suicides per year. Second leading cause of death, 15 to 45, first is accidents. And only 50% of Americans get properly treated for depression. And it is getting worse. Both depression and suicide in the 21st century are increasing by 1% a year, roughly. Now that's 1% from what they are. So from 7%, next year it would be 7.07%, 7.14%, like that. Not 7% to 8% to 9%. That would be a huge jump. Increase is especially marked in adolescence. Some people blame it on smartphones. There have actually been studies to show that smartphones have increased levels of depression in adolescence. And military veterans, and obviously that goes because of all the wars that we love to fight. We haven't, throughout 21st century, we have been at war. And that's taking its toll on military veterans, who are by far the fastest growing demographic for suicides. And this is in spite of the fact that prescription medications, antidepressants, have been prescribed at an increasing rate. In the last 40 years, there's been a 500% increase in the rate of antidepressant prescriptions. This and the 40-year mark is because 87 was the year that Prozac came out. The celebrated drug, the only drug to have been on Time magazine twice. Have been on the cover of the Time magazine twice.
Before that was Valium. It was in the 70s.
Right. But I'm going to talk about the different types of depression. The major depression, that's a classic type of depression. It's episodic and recurring and relapsing and remitting. So in theory, if you have an episode of major depression, you don't get treated and you don't commit suicide, then you will recover. The average time of recovery without treatment is 2 years, but it can last for years. Women are much more susceptible to major depression than men. Another type of depression is persistent depression. Think of Eeyore, and you have a classic example of persistent depressive disorder. I just want to be left alone. It's a lower grade depression, but more persistent. It's kind of lasts a lifetime. It's sometimes been called a personality disorder. It can still be quite debilitating. It's had many other names. Yes?
You mentioned that it's higher in females than in males? Because I thought the suicide rate was higher.
The suicide rate is much higher in men. The rate of completed suicide is higher in men than women, but the rate of depression is higher in women than men.
So that's because we deal with it and men take their lives.
You said it. Bipolar, which is again cyclical, and there are extreme lows and extreme highs. It used to be called manic depressive, same thing. But the highs may not really be highs. They could be kind of semi-highs, which is called hypomania. Sometimes it's a mid-state, kind of an agitated state of irritability and a kind of depression along with hypomania and increased energy. And depression is often the first sign of bipolar disorder. Adjustment disorder, which is basically means that it is time limited and clearly related to a major stressor. According to me, adjustment disorder is if you just go with normal sadness and you actually end up in a mental health clinician's office, they have to diagnose something because they want to bill the insurance company. So we have come up with a disorder called adjustment disorder. It's a stupid disorder. It's a stupid label. But as I said, insurance companies are fooled and they actually think it's a disorder, so they pay us.
But a lot of times, in fairness, a lot of clinicians will use that diagnosis so they don't label their patients.
That's true. Sometimes it's done as an advocacy to avoid stigmatizing and labeling patients. That is very true. Thank you. But anyway, it's not a diagnosis. It's a label. If you can understand the difference. Seasonal depression, an interesting variety in which kind of you feel good and kind of cheerful in summer and kind of down and low in winter. All of us have that to a certain extent, but seasonal affective disorder is when it's There are fairly wide variations. And very interestingly, just exposing the person to light, sunlight equivalent, go to a tanning salon, and it seems to treat the depression in winter. So it's something related to light. And it's obviously much more in the northern, the temperate climates than. I'm from India. We never have seasonal affective disorder. Are you kidding?
Above the 45th meridian.
Exactly. Postpartum depression, a particularly severe type of depression, and a very common depression, up to 20% of, up to 25% of moms, doesn't start immediately after delivery. That's a myth. That's called the postpartum blues or whatever, and that's a more normal condition, and it's probably because of hormonal adjustments. But true classic postpartum depression starts a few weeks after delivery, up to a few months, and it's been noted up to the start of it has been noted up to a year. The one thing about postpartum depression is that infanticidal wishes, the wish to kill your child, are common in postpartum depression. They can both be a cause of the depression because you feel very guilty, and they can be an effect or a symptom of the depression. And that's one of the reasons why it becomes important to treat postpartum depression. Substance induced, I don't think I need to spend much time on it, but most of the illegal drugs can induce depression, either during intoxication stage or withdrawal state, can also be induced by a lot of medications, especially antihypertensive medications, steroids, hormones. A lot of the medications that many of you may be on in this room has potential to cause depression. I myself have been in my lifetime on 2 medications that I believe was causing me to be mildly depressed, and I stopped them because of that. One was propranolol, a beta blocker for hypertension. One was Nexium. Both of those can cause depression. So they are very common drugs that a lot of people take, which can cause depression. Masked depression. This is particularly the difficult problem clinically. There are people who feel depressed internally. They have all the other stigma of depression, but their affect is either smiling, and it's a mask that they put on, or their affect is just irritability and anger. This is particularly true of adolescents. It's very rare for me to have, I'm a child psychiatrist, by the way, child and adolescent psychiatrist, and it's very rare for me to have an adolescent patient who is depressed who will come and tell me I feel sad. No, they're either angry or they're actually smiling. But then you see of how they're functioning, of what they're doing, with their behavioral disturbances, their relational problems, their problems at school, their productivity problems, their concentration problems, you realize that they're depressed. And this is a masked depression, classic in adolescence, and difficult to kind of diagnose. Atypical depression is a term that refuses to go away, even though it has been taken out from DSM-5, but atypical depression is a type of significant depression. So in that sense, like major depression, but instead of decreased sleep and decreased appetite, they have increased sleep and increased appetite. And this type of depression seems to be much more resistant to medications. They also have something called rejection sensitivity. So what you were talking about, kind of that they have abandonment issues. They feel they're very, very sensitive to the slightest bit of rejection. Childhood depression. So childhood depression technically is depression before age 12. Childhood depression is not very common, but still common enough that it should be kind of thought about whenever you have a child who is having some problems. Again, childhood depression, like adolescent, will mostly be masked. It's often very often has atypical features. And the most common presentation is academic difficulties or behavioral problems at school. Oppositional defiant disorder, when it is not a part of ADHD, is generally a kind of a symptom marker for childhood depression. And in children, IMO therapy should be the only treatment, because antidepressants are well known to significantly worsen depression in a high percentage of children. And they also have now documented several kind of a huge frequency of suicidal ideations being caused by antidepressants in children. So therapy should be the only treatment.
I have a question. Since you said it's atypical, so it's masked, so they tend to.
No, atypical and masked are different. Masked is when the presenting affect is not sad. It's either happy or angry. While atypical is when you have increased sleep, increased appetite, increased weight, and rejection sensitivity.
So if you are masked then, as a child, and it's not treated, what does it develop into once they're past the age of 12 and maybe in their 20s or 30s? If
Well,
they're treated?
I mean, it doesn't develop into anything in that sense. I mean, you just have recurring episodes of depression, but that depression can lead a very, destructive trail, because you don't do as well at school, you don't develop the academic fundamentals. That leads to decreased that leads to academic failure, which means that you may not get the career that you're capable of, or the jobs you're capable of, which will lead to long-term financial problems. You do not develop relationships or friendships, that leads to long-term relational problems. They sometimes actually cannot develop the social skills, which are so, the latency age, 6 to 9, 6 to 10, is so important for developing how to make friends. And if you're depressed during that phase, you do not have that basic skill. You go into adolescence, which is already a very awkward period for friendships because of all the hormonal changes. And then they don't have that kind of bedrock of relationships. So it can lead to all kinds of complications.
So they're technically the masked type, they can stay masked, but just an adult with those issues that you just described.
Right. Women experience depression. Women experience the whole world different than men, including depression. On one hand, it's much more prevalent. Although, interestingly, if you add up the number of women who are depressed and alcoholic and the number of men who are depressed and alcoholic, the numbers match. So the theory is that a large percentage of men don't become depressed, they become alcoholic. The other thing is that in many non-Western cultures, where it's not that important for a man to be macho and for a man to be, not be able to cry and not show their emotions and be, the man, Depression statistics are the same in men and women. In which cultures in which men are allowed to be more effeminate have similar rates of depression in men and women. So this may not be a hormonal thing, this may not be any genetic thing or anything which is fundamental to the gender. It may be something much more cultural. That if you're a man, you go to the bar, drown your sorrows in a glass of bourbon. Men also tend to resist treatment, which is possibly why they attempt more, they complete suicides more often, even though they attempt it less often. So they're more successful in their suicide attempts. Now this is, of course, don't consider alcohol to be a slow poison. Much better at it, much better, unfortunately. We're much better at killing people, including ourselves. Men also have more classical depression. And in fact, the fact that classical depression is called classical is because because all of this classification was made by men. If a woman had started classifying depression, the classical depression would be the atypical depression. Because women have far more depression than men. and women have far more atypical features than men do. So classical depression is not the most common depression. It's simply the most common in men. And if it's common in men, that's the normal. It's the you who are all the problems. Another thing, depression would never have been as sharply demarcated from anxiety as it is right now, because women rarely have pure depression or pure anxiety. Women generally have an admixture of anxiety and depression. It's men who have either pure depression or pure anxiety. And that's why DSM has depression and anxiety as two completely separate things. They're not. They are at some fundamental level very similar. And one clue we have of that is that most of the medicines that we call antidepressants are also anti-anxiety agents. So clearly there is some level at which they are similar. But that's not how men experience it, and so that's not how it is. Right, treatments. There are a huge number of treatments for depression, and that has to be kind of, it can be easily deduced from the fact that depression has been in all cultures and for so many centuries on all civilizations. And so, one good treatment is the saliva of a dog. But anyway, it is true. It is absolutely true. They have antidepressant properties, the saliva, when your dog licks you. But what I would suggest, and this is not what you'll find in textbooks, is that mild to moderate depression should not be treated with prescription medications. They should be treated with what I call home remedies, which include, and we're talking mild to moderate depression. We're not talking about people who are suicidal. We're not talking about people who are hallucinating. We're not talking about people who, haven't gone to the work for the last 3 weeks. We're talking about the mild to moderate depression in which basically most people are functional, but they have some loss of sleep, some sadness, some irritability, some loss of energy. Maybe they've lost a few pounds of weight. Maybe they're not as interested in going to their friends on Saturday night bowling. Though that's a population I'm talking about. Active culture yogurt has been shown to be as effective as Prozac in mild to moderate depression. Active culture, not the saffron, make sure it's pure. Music therapy, well chosen music, not gangster raps. 30 minutes plus of exercises 5 to 6 days a week regularly, as effective as Prozac. All of these treatments have been shown in studies to be as effective as Prozac 20 milligrams for mild to moderate depression. Yoga, mindfulness, meditation, magnesium. In fact, many people believe that part of depression is a magnesium and vitamin B12 deficiency syndrome. 5-hydroxytryptophan, which is an amino acid you can get in Vitamin Shop. It's a precursor to serotonin. It's a precursor to what Prozac increases. And SAMe in St. John's wort. That's the list that I would recommend, and I do recommend to my patients for mild to moderate depression.
Did you say which of the magnesium forms did you happen to mention?
I said magnesium with vitamin B12.
Thank you.
Do you also find that patients who do exercise, it helps the antidepressant medication to become more effective?
Oh, absolutely. Thank you for bringing that up. I don't think that you should stop all of this just because the depression is severe. You may have to add a medication or other treatments, but you shouldn't stop it, especially if it is working to a certain extent. Many of my patients, they feel that, oh, now I started on a medication, I'm going to stop all the things that, had maybe 30%, 50% benefit, not enough. No, continue those. That way you can get away with a smaller dose of the antidepressants.
Could a probiotic take place of the first one?
So the research has been done with yogurt, but presumably it's the probiotic properties of yogurt. So we're waiting for that research. Yes,
Saffron is pretty expensive.
I know.
Because it's so expensive, you want to use it wisely. What's the best way to use it?
Oh, capsules. You don't want to put it in food because you're not going to have, your dietary habits are too different.
Has there
I mean,
been-
you're meaning most of us. I didn't mean you particularly, sorry.
Has there been any kind of study like the flowering parts of other edible flowers?
Yes, there are rosacea and there are a couple of other flowers which have also been shown. I only listed the ones that have, according to me, significant enough evidence that I actually do recommend it. There are others which have more shaky evidence.
Essential oils?
Same thing. The evidence is less. I mean, I don't mind you trying it, absolutely not. Especially in children.
Can I just recommend something?
Sure.
Eucalyptus
Yes.
is
Yeah.
really good for you for depression.
Yeah.
And rosemary?
Yes.
When to seek professional help? I think we already been over this. The emergency is when there are suicidal ideations or hallucinations. The urgency is when there's severe depression which affects day-to-day functioning, or when there are rapid or severe mood swings, or when you have prolonged depression which is resistant to many of the home remedies that we talked about. And those are the times when you come to us. Psychotherapy, in my opinion, should be the mainstay of treatment for depression for most people, if not for everybody. And cognitive behavior therapy has been the one that has been studied best for depression, but I believe that there are a number of therapies which, if done effectively, will help with depression. It does kind of depend on a patient-therapist fit, unfortunately. Not all therapists are good for all patients. And it does take some time to start working, but psychotherapy is a major modality of treatment and should be used for depression much more than it is being used. So there are 30 plus antidepressant medications on the market. This is not to knock them off. I think they are definitely useful, sometimes life-saving. However, I think that antidepressant medications are way overprescribed, and even more important, they're way overrated. It has been shown that that there's only a 70% chance of the antidepressant medications making you at least 50% better, and there's only a 30% chance of an antidepressant medication actually curing depression. I find that to be a very small percentage for all the hype that it has in the society. 30%, that's it. 70% of patients still feel depressed even after adequate doses of antidepressant medications for adequate amount of time. They still feel some residual depression up to 50% of their original symptoms. So that's not a very encouraging statistic. And then the side effects, I think especially the side effect that antidepressant medications can make you worse is underrated. You know, Scientology, and I never thought that I would praise Scientology, but Scientology was the first one to bring this to attention, that Prozac can make you suicidal and violent. Back in the 90s, if you remember, early 90s, it was a big brouhaha. All the psychiatrists said, oh, you Scientologists, you don't know anything. Oh, this is all cult science, and Scientology is a cult. I'm not trying to, but they were right about this, and we have to give it to them. And you know, even Nicholas Cruz was on antidepressant medications. The sheriff who shot up somebody in near Pasadena was on Zoloft, just started. I'm sure you remember that. So many people who turn violent, you dig into their history, and the media reports it as, oh, this is a mental health problem. We need there's a mental health crisis. Yes, there's a mental health crisis in America. Fine. But the point is that they were in treatment, on antidepressant medications. I think that should give everybody a pause as to how many of these people were on antidepressant medications. And I think that it's way underrated. There are reliable articles which claim that it is up to 40% of patients.
In one of your earlier slides, you had, as one of the symptoms of depression could be low self-esteem. Is there
chicken or the egg?
Is it possible that that could happen that way?
I think both are possible. There are lots and lots of medications that psychiatrists would love to put you on once you go to a psychiatrist with a complaint of depression. They'll put you on a second antidepressant because the first one is not enough. They'll put you on anti-anxiety agents because, especially for women, depression and anxiety go hand in hand. They'll put you on hypnotics because difficulty falling asleep is part and parcel of depression. They'll put you on mood stabilizers because the antidepressant has now created some labile mood. They'll put you on antipsychotic medications because depression can also cause hallucinations. They'll put you on boosters because antidepressants are not enough. So they'll put you on Ritalin or they'll put you on thyroxine, on and on and on. Basically, if you're going to a psychiatrist and you're on 4 or more medications, please ask them to reevaluate the need for medications and to see if there's a different diagnosis possible. This is all too common a story that you just, and I'm not knocking down all psychiatrists, and it's not the job, but it's kind of part of the whole, where the whole field is. Okay, I think we'll skip this. There are several other treatments, some experimental, some promising, including LSD and psilocybin and marijuana, exciting treatments. Ketamine, which is another drug, ECT, which, by the way, one flew over the cuckoo's nest has really done some bad things to this country. ECT is one of the best treatments for depression. It treats all the types of depression equally, whether it's bipolar, atypical, all of that. It has far fewer side effects than antidepressant medications in the long run. It's just that it has been stigmatized so badly in this country that very few patients accept it.
Which one is that?
ECT, electroconvulsive therapy. They zap you. How to prevent depression? In 5 simple steps. Socialize. The greater your social circle, the less likely you are to be depressed. And this is a remarkable fact. Not only are you less depressed if you have happy friends, if your friends have happy friends, you're less likely to be depressed. Think about it. If your friends have happy friends, you are less likely to be depressed. That's how infectious happiness is. So friends meaning that includes family members, people you're close to. Volunteering. When you give of yourself, right? Remember, depression is withdrawal into yourself. When you're forced to give yourself in voluntary causes. Or you give gratitude, same thing. You're coming out of yourself. It's an antidepressant, believe it or not. The true charity that you do is to yourself when you give. Because the person who benefits the most is yourself. Find a passion in life. Do something which is inspiring. Do something that you feel good about and do it with passion. That will be a wonderful antidepressant. And of course, it goes without saying, a healthy lifestyle, balanced diet, exercises, good routines, good sleep and eating routines, yoga, etc. And that is the end of my little talk. It went on a little bit longer. Thank you.
You mentioned transcranial magnetic stimulation. What's the research on that?
So the TMS is a relatively new treatment. It's kind of like ECT light. So in order to bypass the stigma that was there around electroconvulsive therapy, putting electrical current in, we meaning they came up with something which is a transmagnetic. So they essentially does the same thing but through magnetic pulses, kind of like an MRI, instead of through electrical impulses. And TMS is not as effective as ECT, but it is also much, much easier to administer. It's a very simple machine. You just sit in a chair and they kind of, you feel a little buzzing on your skull, and you go home. It's all very pain-free. And no memory loss. The memory loss in ECT, incidentally, is not from the ECT. It's from the anesthesia.
From the anesthesia administered prior to the ECT?
I am old enough and come from a country poor enough that if patients do not afford anesthesia, we used to give ECT without anesthesia. It's a horrible thing to see, especially if you're a relative, but we never had any amnesia afterwards. Just for that day, that's it.
Is that permanent memory loss or just temporary? With SE?
Temporary. It generally recovers in such. Only the day off is permanent.
You didn't really touch on like hormones, so.
I'm sorry, what hormones?
Yeah, touch on hormone causes of hormone imbalances, like, so as you age, obviously you get all these things happening to you, which could look like mimic depression, but it's actually a hormone imbalance.
Right, I did actually touch upon it, but there was a time when the types of depression I was going through very fast. But yes, hormonal imbalances can also cause depression.
If somebody has any further questions, I'll let you, maybe Dr. Shah will stay further, and I want to thank you for giving extra time to us. This is a marvelous lecture, and thank you so much. I learned a lot. If you want to stay out-